I'd like the entire rheumatology community to think about autoimmune diseases a little bit differently. We've been, diagnosing patients using criteria that were designed for clinical trials. And I'd like us to start thinking about people who have earlier stages of disease. I have co-opted or stolen this concept from the type 1 diabetes literature, where we have stage 1, stage 2, and stage 3 disease. And so I think when you talk about prevention, it's talking about moving from one stage to another. I realize that what I'm talking about is aspirational and requires a lot of cooperation among international groups to help us to define these stages. But in general, pre-stage 1 is somebody who is healthy, has no health concerns themselves, and has no evidence of a dysregulated immune system. And then stage 1 are people who have evidence where their immune systems have sort of taken a left turn, if you will, and are maybe more active than previous. There is mounting evidence in the lupus world for a more widespread dysregulation in the immune system, as measured by certain blood biomarkers in people who are destined to develop lupus, and that would be stage 1. Stage 2 is when those patients or those people begin to exhibit some symptoms, and as I said, it might be something as simple as a mild rash. It might be some joint pain, or it might be some other evidence of the immune system damaging tissues, and sort of one of the easiest ones that we see are low white blood cell counts, low platelet counts in a patient's complete blood count that they would normally get at their primary care physician's office. And then stage 3 is right now defined by the criteria that were developed over the last 40 years or so for the classification of patients to be put into clinical trials, and that stage 3 criteria really are based on a lot of clinical features, lupus nephritis, classical skin rashes, arthritis, etc., but not well defined biochemically as certain of that somebody has lupus. And so I would hope that our field could move to a point where we could actually use objective features, including blood biomarkers, maybe other things, that would help us define each one of these stages more accurately, because that's when we're going to be able to do the research that enables us to show what kind of events or interventions will actually prevent lupus or prevent its progression.
But lupus is at this exciting juncture where we finally have newly approved therapies that are targeted in their actions and that are working together in combination. And so it is time to start thinking about this concept of disease modification. How can we slow damage progression in our patients? The proposal was to look at non-renal lupus and also lupus nephritis in the following way: to look at 3 different time points after starting a therapy. At year 1, in which we expect to see reduction in disease activity, reduction in flares, and then years 2 through 5, where we continue to see sustained improvement in disease activity, reduction of glucocorticoid use, reduction of flares. And then at years greater than 5 is when we can definitively state that a particular therapy is disease modifying, because the gold standard is to ensure that there is not progression of damage. And that can be damage in various organ systems as measured by the SLIC damage index, but also specifically when we're talking about lupus nephritis, which was the component of the presentation that I gave, looking specifically at a delay in progression of chronic kidney disease. And so we break it up into those time points. And the reason for that is that when you first start a treatment, you want some early indicators that the treatment is working in the correct way. From phase 2 and phase 3 trials that support the use of combinations of immunosuppressive therapies early in the treatment of lupus nephritis. And our 2 newly approved therapies are belimumab, to be used in combination with either mycophenolate or a low-dose cyclophosphamide, or voclosporin, which is a calcineurin inhibitor, to be used in combination with mycophenolate. So these wonderful data now that show that the use of these combinations of therapies are more effective than our standard conventional therapies alone. Instead of starting with one medication and ramping up if people don't respond to it, let's flip it around and start with multiple medications, which, granted, is challenging from the perspective of a patient. However, I think that it's up to us as physicians, as well as our advanced practice providers in our clinic, our nurses, our medical assistants, wonderful people. We can educate our patients, make them partners with us in care, and show them that if we can get on top of this lupus nephritis early with these medications, that they're not going to be on them forever.